So you may notice that we have 4 lovely panelists and 1 empty chair at the front because unfortunately Gary Teare, who advocated so hard for this session yesterday, has a flat tire on his rental car this morning. So we are hoping that there will be a just-in-time arrival that will smoothly and seamlessly fit in with the flow of the panel. If not, we are prepared to juggle as required, so that hopefully Gary will be able to insert himself in as we come. But welcome to this session on dashboards and decision support tools. We do have a lovely mix from both across the country and also from different areas and levels in the health system for you this morning. And what we agreed when we were planning this session was that we would do very short introductions so that you could have maximum amount of time, both to hear from our panelists, but also to have discussion in the room and amongst each other as well. So let me do those short introductions to get started. So Raza Abidi is Professor of Medicine at Dalhousie University. And joining us, obviously, from Halifax. Next to him is Stéphane Robichaud, CEO of the New Brunswick Health Council. Then Gary, in his chair, who I will introduce now anyway as CEO of the Saskatchewan Health Quality Council. Then Jeff Menzies, who's next to Stéphane, is Senior Analyst with the Non-Insured Health Benefits Program at the First Nations and Inuit Health Branch at Health Canada. And anchoring our panel is Kathleen Morris, over on my left, your right, Vice President of Research and Analysis at the Canadian Institute for Health Information.
So today I'll be talking about some of the work that we are doing in terms of decision support, and there are 2 projects that I'll be sharing with you. And the first project, which is around the physician's perspective of analytics and information. Just to give you a very quick background about this particular project, it's called Impact AF, and the intent of this particular project is to equip and empower family physicians or primary care physicians to manage atrial fibrillation at the primary care level, which is a specialized care actually in a tertiary center. How do we do it? Right. There are a couple of things that are in the background. Number one is some heavy-duty analytics is going on, whereby we are collecting data from the patient, from the hospital, and also from various labs that the patient may go to, analyze it, and then develop models which would be projected over here. And then the second is computerization of guidelines, which would trigger rules based on the analytics that we have. So we both have a knowledge and a data-centric approach in what we are doing over here. Right. So moving very, very quickly, right, the intent of these dashboards is actually 3. Number one, right, we want to have the physician a 360 view of their practice with respect to the disease that they are managing and also their patients, without a cognitive overload. That is the key over here. Number 2 is the meaningful use of information and the analytics. And secondly, the ability for them to drill down as they wish, right, as opposed to presenting everything that is available through the analytics. So very quickly, if you look over here on this side, this is a physician's dashboard. As soon as they log in, right, they are seeing all the patients who are in atrial fibrillation patients, and these patients have actually been stratified with respect to severity, and as the severity of a patient is detected to be higher, right, they move up, right? Notice this is a living system. It is always on. It is always listening to the data sources, and as soon as it detects a trend for a particular patient to be leading towards an adverse event, it starts triggering the rules and would start popping up the alerts that are over here. On this side, you're seeing the dashboard for, again, the physicians. At a very high level, it is telling the physician how he or she is doing with respect to their patients in general at the practice level. So these are the diseases, these are the EGFRs that the patients have, and then the drugs that they have put them on. So it gives them a good view of how their practice is faring with respect to the norms. Now, as soon as we go to the next level, right, again, this is the same project, same dashboard, but now the physician has gone 1 level deep and is looking at the patient itself, right? And notice what is happening over here is that these are the alerts that have been generated over here, and then this is the entire view that is relevant for atrial fibrillation for a physician to be aware of for this particular patient, both what is currently happening and where it is projecting to if no intervention is taking place. So in one screen, right, we have all the information that is relevant without any cognitive overload. And if the physician wants to drill down, all of these graphs, which are representative of a single patient, can be drilled down further, right? And here are the different scores that matter and where the projections are leading to over here. So this we regard as the physician's view. It's a very 360, very simple view of how the analytics is actually presenting itself and helping the physician detect what is to be done and what are the trends for individual patients. And this is not necessarily the analytics, but this is the end of the analytics, that as those alerts have been detected, right, then based on the clinical guidelines, these are the recommendations that are popping up, and these are the reasons for those recommendations. They tie back to the analytics that has been done and also the clinical guidelines. So this is the end point of this exercise, where the decision support is now becoming visible and interactive to the physician, and they can choose or not whether they accept the recommendations that is based on the analytical models that we have over here. So this gives us a physician's view of how things are actually panning out with the clinic and with individual patients, and it is proactive and it is personalized. Moving further, right here very, very quickly, this is the patient's view of things. Now, the intent has completely changed in this particular visualization, because now what we want is to have a patient engaged, and the way we are doing it is that giving them a complete snapshot of their life with respect to the disease, so that they can see where they are going, and what is actually happening in their life with respect to the atrial fibrillation condition. So you would see that this interface is actually divided into months, and in each one of these, right, you have these different icons. The legend is over there. It is actually telling you how many of such events are actually taking place. And obviously, if a month gets more populated, then it means that there was a lot of activity regarding atrial fibrillation in that month, which the person may want to investigate further. But the intent over here is to make the patient aware of how their disease is progressing over a longitudinal period of time. And the patient can actually drill down further as they want and see what is actually the alerts and what did actually happen. The scores are also visible over here, which is in this particular case, right? So here it is also showing them as a patient what their critical scores are with respect to HAS-BLED and CHAD-VAS, which is the three main elements for atrial fibrillation. Where do they stand? Where they are going with their current trends. And then they can actually drill down further. All of these are interactive. So notice the intent over here is to give a snapshot first, engage them, and bring them back in as and when they choose by drilling down further into any one of these. These are all drillables further, and you can go to a single day event if one may choose to do that. So that is how we are engaging the patients, bringing all the information that they need to know in a very simplified manner, in a very simple, cognitively simple fashion that they can relate to it, and then also make choices that would impact the scores that are over here. Lastly, this is the Policymakers View, and this is a different project where we are looking into the provincial pathology lab, and it is looking into the management of resources and also the performance of the physicians in terms of utilization, both over and underutilization of blood work requisitions. So now this is a view that a policymaker can actually look at, and they can drill down at an individual physician level. So this is the physician that they're actually looking at, and this is the number of requisitions that each individual physicians may have, right? This is the breakdown of the requisitions that they have. And this is the more interesting thing, like that for an electrolyte panel, the number of requisitions is this much, but the results that are coming back, these were the normal ones, and these were the abnormal ones, and these were the normal ones. Now, there could be a correlation between why there is more normal versus abnormal for this particular physician. It could be the patient population, which we will see further down. But at a very quick snapshot, this picture actually tells you that if as a policymaker or as an administrator of the lab, what is going on at each individual physician level. Here, now you're provided with comparative analysis. Right? Again, these are all drillable, very interactive. You can touch any of these screens, hover over them, and they will tell you. So this one is actually telling how this physician is going through their prescription behavior over a number of years. And you can compare them with any number of tests that you have. And this is how the physician is actually performing with respect to the provincial rates. And these rates are all adjusted with respect to demographics here. So again, a quick scorecard of how the physician actually is faring with respect to their requisitions. And this could be done at the management level very, very simply. It's all a web-based interface. In fact, we'll be providing this as a scorecard minus a few details to the physicians themselves so that they can see how they are comparing with their peers and also with themselves over the number of years. And this is the last slide I have, and this is what I believe is a very interesting visualization. So here, this is a timeline. This is a timeline of an individual physician, and these are the tests. And this is telling you, right, the number of tests, not necessarily the number of tests, but the order of tests that this individual has actually prescribed and the results. And if you notice over here, right, that this physician actually has a lot of creatine clearance tests being done, but a lot of them are also coming out to be normal. Now, this could relate back to the demographics, which you can drill down further, but at a very first glance, right, there is a point to note over here is that if there is a repetitive pattern of normal tests coming, right, is there a good reason why these tests were prescribed for the patients? So something to look at it. And the last visualization is, this is a clustering that was done. These are both machine learning algorithms. And this is a clustering that is done over here, which is telling us that for this particular physician, right, which tests do they order simultaneously? Why is that important? Because when you have that sheet of ordering tests, right, there are some physicians who could be trigger happy and would be taking quite a few of them and saying, okay, by the way, you're going there, why don't you do this as well, right? It may be reasonable or it may just be a precautionary thing. So what one can actually do is that for this physician, we can actually see that, is there a pattern where this physician is actually ordering tests simultaneously, and then you can go back into the other analysis and see what was the rationale for it. But you tend to see a pattern coming out of these analyses on the prescribing behavior or the requisition behavior of the physicians. So you saw three different kinds of visualizations: the physicians, the patients, and their providers. All of them had their different views, and the grain size of information was quite different in each one of them, and how it is to be used is also different. So with that, I believe I'm done. Right,
Thank you, Raza.
Thank you very much for your attention.
Bonjour tout le monde. Good morning. It's a pleasure to be here. I like the format of a 5-minute presentation, and as I was thinking about that, I was thinking it's like, I've never done speed dating, but that's probably a little bit like what that feels like. So in essence for you this morning, what I thought I'd share with you is just give you quickly a context of the New Brunswick Health Council, just so you have an appreciation as to why I'll speak to you, of what I speak to. Warn you right away, I don't have that many slides, I just have 2 actually. And as I walk through this, I'll invite you to keep in mind something we heard yesterday, which was early in the morning when they said, you know, the importance of first starting to understand what is the problem we're trying to solve. Secondly, having a vision of what that solution will look like. And then thirdly, how technology is going to help us get there. Well, I would say to you that that applies to pretty much any tool. So whether it's technology, dashboards, Lean Six Sigma, whatever you end up using, that approach is really about that management approach that you need to have in place when you look at that. So the Health Council was created in 2008 when we had the health system reform. We went from 8 health authorities to 2. They created also a body called Facilicore New Brunswick, which looked at information technology, purchasing, all of your non-clinical type of stuff. And then we had the New Brunswick Health Council. And the council has a dual mandate, one of engaging citizens in the improvement of health services, and the other one of reporting on health system performance. On engagement, we've had a number of citizen dialogues, and I could speak to great length as to the impact that that's had in New Brunswick on the collective discussion around healthcare. Welcome, Gary. Poor you. On the collective understanding of healthcare. But under engagement, in addition to dialogue sessions, we now have a multi-year survey where these survey results are feeding a lot of our information tools. So we look at acute care, primary health, support specialty on a 3-year basis, and that represents about 25,000 New Brunswickers surveys in that 3-year. We also do wellness surveys with youth in school. And with that one, we do 6 to 12 1 year, K to 5 the 2nd year, 3rd year we don't do any, and that represents about 100,000 kids being surveyed in New Brunswick, where we get data from. So very significant base on our engagement part of our work. Under the health system performance part, 2 areas, population health and health service quality. Under health service quality, what we've come to realize very early on in our work, and I'm pretty sure it's similar in many provincial jurisdictions, is that even though our job really at the end of the day was to take information from the system and inform the public on health service quality, our first challenge was in identifying standardized information that would provide a proper provincial picture. It wasn't as simple as simply taking the sum of everything that was being done, put that together like a puzzle and say, here's where New Brunswick stands. No, wide variations, and variations first of all from the angle of whether or not they had information. So, I used to refer to that as sort of a maturity level in management, as whether or not they were measuring these things. But if they were, very different ways of measuring that. And I had been in one health authority for 1 year, and as a senior, as VP Planning and Operations, trying to get my teeth on information that would tell me what's my problem that we need to solve here. And the problem, my biggest challenge, was whenever any provincial report would come out that would tell me that my institution was performing very well compared to others, those were great reports, but of no use to me. The other part was whenever we'd have a report that would show that among the 8 health authorities, that mine was not performing well in an area, well, every time I'd raise it, I'd get a list of reasons why that did not apply to us. They don't measure this that way, they don't measure that the same way as we do, and so on, so we couldn't use that. So fast forward to the council's work, as we started doing that work, we put a lot of effort in the early years at engaging all the various health professionals, various services in the identification of indicators, not to try to get unanimity, I called it reasonable consensus. And once we start getting that, well, it was very interesting. What's happened to us now is whenever we come out with a report, we get lots of people who don't like the results, but very, very little time, even sometimes no time at all, questioning methodology or the validity of the information. And that is huge. But that required a huge investment of time early on. So from a health service quality perspective, what we've come to realize, and New Brunswick, just for context, is that we do very well when it comes to avoidable mortality linked to timely access to quality care. We're in the top 2 performing provinces in the country, more often than otherwise, so life and limb do very well. But when it comes to prevention, or those mortalities linked to preventable services, we don't perform so well. So the issues of chronic conditions, particularly important for us in New Brunswick. Ambulatory care sensitive cases, as was mentioned yesterday, huge issue for us. We're almost double the national numbers. We are double in many parts of our system. And there, what I want to relay is, what we found is, when we can bring the information locally That's where it gets traction. And that's where it helps people locally to identify that solution that they want to solve, and it influences then the impact of whatever dashboards, whatever systems they put in place, because they have a much clearer appreciation that's where they want to focus. So from a health service quality perspective, huge advances, and that's been very helpful. But it's linked to the point I made yesterday. What we've realized now for a number of years is that even though now we can put this information in front of our managers, we have to really seriously recognize that the culture of management has not evolved with this type of information being available. At first, I thought my work was great, because when I showed the info, there was no need to convince people we needed to make shifts towards primary care, and here's the evidence, and here's what needs to be focused on, and here's where you stand. But 4 years later, it's realizing we're having that same conversation over and over again. And on the Monday morning, people are not equipped to then translate that into the types of decisions and support tool that they need. So lastly, and I'll finish with this, and it's the 2 slides I picked for you this morning, is there's a lot of talk of patience in these types of conferences. And right away, as a Canadian, as a New Brunswicker, I'm not a patient. I'm a patient when you call me a patient, but I'm first and foremost a citizen. And what we're learning of our health system is if we did a far better job, fewer of our New Brunswickers would end up being called patients, because we prevent a lot of these conditions. So on that end, under the population health part of our work, and understanding determinants of health and so on, is where we've seen a huge impact. In 2014, we developed what we call My Community at a Glance. What it is, it's something we're going to have a 3-year cycle, so next spring of 2017, is going to be the update. New Brunswick is now divided because of a lot of the surveying, the types of indicators we've been able to identify. 33 communities, 300 indicators, information from 30 sources. There's contextual, there's determinants of health, and there's health outcomes. And what's been very interesting for us is to see the impact this has had on conversations locally. So where we used to be invited in the community to talk about health, but where the agenda was really how do we convince government to either increase the size of our hospital, open a community clinic, or that type of stuff. Now, when we present this information, they talk about physical activity level in the communities, literacy levels, the percentage of hours their youth sleep per night. So 30 to 40% of youth sleep at least 8 hours a night. If you're in the education system, that has an impact. If you're from a family perspective, this is something that's of much value to you. So when they go onto our tools, they can click on the community in which they live, get that information, and we've also done some comparison tables for them. So if you're in a small rural community, it's much more difficult. You wouldn't want to compare yourself to an urban center. So we've grouped them and tried to facilitate comparisons for them. So from a population health perspective, we've really seen how local information has a big impact. And from a population health perspective, we're seeing how this information is having an impact, not only for our RHAs in their needs assessment evaluations, but also in helping to provide oh yeah, that's very convenient. Some common language and common objectives around the things they need to focus on. So that's it. Thank you.
Good. Well, recovered from a flat tire, and here I am. So, when I was conversing with Brent Diverty of CIHI around this session, one of the things he said was, one of the things you want to leave people with is, what should people be thinking about when their IT department comes to them with the next grand plan of what they want to develop and do and great ideas. So I thought I'd just tell a little story about our experience in Saskatchewan. I went out to Saskatchewan in 2005, really to lead the measurement work at the Health Quality Council there. And really my mission was to get publicly accessible information on the quality of healthcare on the web, so that people could see it. It would be transparent. It would be continuously updated. It took us a few years to get there, but we eventually did create a dashboard system which we call Quality Insight Online. We started reporting on paper and then having PDFs and so on, and eventually built up to an interactive tool. And we're quite proud of this tool. It's a tool that we had to really develop from scratch because we wanted to use the best practices in quality measurement, which really speaks to measuring over time rather than bar graphs and this quarter versus that quarter, or last year versus this year. And we wanted to ultimately be able to build into it some statistical process control rules or that sort of thing, so that people could use this to really be able to see what the trends are, but also to be able to say, are these changes that are happening actually statistically meaningful? We had a working group, a provincially representative working group, working with us to develop this tool. We worked with a local software web developer. And when you go to the front page, this is what you get. You can look at indicators by the whole province. You could look at them by region. You can drill down to hospital level if for some of the indicators. It depends on the data source. There's well over 100 indicators on there that cover things from the various dimensions of quality, but also population health and those sorts of things. And as you can see, it's graphically set up so that you can pick the indicator and click on the little graph there, and it'll actually pop up the graph. And you can drill down then to the different levels. And we felt this was a really good addition to the public transparency and public information space. This is sort of what when you drill down into one of those graphs, what a graph would come to show. The illustrative thing here, this is from a patient experience survey that we ran. We ran patient experience surveys where we would get data on a biweekly basis from patients discharged from hospital. So we were constantly sending out the surveys, getting the data back, updating the website monthly. And the amazing thing is that line stayed flat for 5 years. And really what it spoke to us about was measurement in and of itself isn't going to do the trick. You can put the information out there, highly validated, totally bought in, as Stéphane was saying, when you put in the time at the beginning to get people to buy into what the information is. But what was missing was really the foundational work at the front line and at the level of management to create the culture for wanting data, for using data in decision making. And so really that was the lesson learned, if you like, and the thing that is the takeaway. You can build the tools, you can do all the validation of the measures, you can make it scientifically and managerially relevant, but if the folks that you're developing this for don't have a culture and a practice, an actual habitual practice of looking for and seeking data in their decision making and using it in an ongoing way, it becomes something that might be used occasionally or might be used at key points of needing to make a point to the ministry around funding or that sort of thing, but it doesn't become something that gets used on an ongoing basis. More recently, in the last number of years, we've done a lot of work in Saskatchewan. You probably heard we had a big emphasis on lean. Lean is a lot of different things to a lot of different people, but one of the brilliant things about lean is that they really focus on engaging the front line in thinking about what it is they're trying to work on and actually huddling on a daily, weekly basis around data boards, essentially, that are publicly displayed in the hospital unit or the clinic or whatever. And they use these to motivate and to track the changes that they're trying to make in their region or in their unit or whatever. So, all over Saskatchewan now, you'll see in hospital units, in primary health care clinics, in long-term care facilities increasingly, you'll see these types of things up on the wall, and teams gathering in the hallway on a daily basis to talk about what it is that they're working on that day, what it is happening, and how the measures are demonstrating for them what improvements they're making. This also happens at the provincial level. We have something called the Provincial Leadership Team, which is all the CEOs, the board chairs, some physician leaders, the deputy minister. And this is the group that sets the agenda, the priorities for improvement for the province. And they have a big wall built at the Ministry of Health, where we gather on a quarterly basis from all over the province. It's a big investment of time, and it's a big investment of people's thought space, but we gather around the wall of measures that we're tracking and using to really guide and monitor our work on emergency department waits, or primary health care access, or the various areas that we're doing strategic improvement on in the province. And it's been this practice that has driven a desire for data. It was incredible once we started to do this sort of work, the draw for information and for data that has come out of this. Now, the issue here is that it's an investment of time, and it's an investment of capability building. Typically, and there was a conversation yesterday about management in healthcare and how perhaps ill-prepared we are as managers to lead billion and multi-billion-dollar systems. The investment particularly important for frontline managers. So those nursing unit managers in hospitals or in long-term care or home care. We've actually got a modular learning program now for them to learn how to do what we call daily visual management. The huddles being the most visible component of that, but how to work with their team to identify measures and really sometimes very simple things that they do in the moment and track in a pen and pencil type of way. But then they can also have on their walls related strategic measures from the region that relate up to provincial priorities. This has really changed the conversations in hospital units and in various places where healthcare is delivered. But it takes an investment of training. Like I said, we've got this modular training program, which it takes them about 9 to 10 months to go through. They can do it online with a sort of a flipped classroom type of approach, or they can do it with a more classical classroom-based teaching approach. Right now, there's about 700 managers across the province enrolled or completing this course, and more getting registered. So I guess my takeaway lesson for folks would be having the website is great, having the tools are great, but the draw for the use of that and the actual uptake of that won't happen unless you've got this type of activity happening at the front line and at the leadership level. And it's, I would say, really worthwhile for a health system to invest here in the education and the habit forming, at least at the same time, if not before, you make a big IT investment in dashboards.
So the example that I'm going to give today is a little bit different than some of the ones that we've seen so far. And I'm going to take us through a situation that we've encountered with the Non-Insured Health Benefits Program and the way that we're using data and the information that we have to address some issues pertaining to client safety. So quickly, just a brief overview of our program. We have approximately 825,000 eligible clients across the country, and we provide 6 benefit areas for them. And what I'm going to focus on today is the prescription medications. And we're using data to support quite a few client safety initiatives. So I'm going to speak specifically about the provider and prescriber surveillance activities that we have, but we're also using the information that we have from our claims processor, the transactional information, to support other client safety initiatives. So a bit of a background. In 2012, we implemented the SaaS fraud framework for healthcare to support our pharmacy audit program. And as part of that implementation, there was a data warehouse that was developed, which contains now approximately 280 million rows of information going back from 2000 to present. And this information previously was only accessible to us through a web-based business intelligence tool, which limited our ability to conduct in-depth analysis. So I'm setting the stage here with this slide, and it's not the prettiest visualization, but it shows benzodiazepine utilization in a specific community in Canada in Q1 of 2011. And the size of the dots is the number of clients that a pharmacy would have receiving benzodiazepines. The vertical axis is the percentage of their claimants, and then the horizontal is the median daily dose within the pharmacies. So this is kind of the baseline. We moved to 2012 in Q3. Through the analysis of the data and some on-the-ground information from professionals within the area, it had been brought to our attention that there had been a significant increase in the volume of benzodiazepines and the prevalence of their use. And it's quite interesting that actually this situation, there was a handful of pharmacy providers that were actually affecting the national trend for our total milligrams of diazepine use. So as a result of this issue, we developed the Pharmacy and Prescriber Surveillance, Prescription Drug Abuse Surveillance Program with NIHB data. So it's moved on to now we have a systematic means to evaluate pharmacies and prescribers using our transactional information from our claims processor to look at a provider or prescriber's behavior over time, assess certain risks that may be present within their dispensing or prescribing practices, and it provides a means to compare them against their peers and engage with them as appropriate. So there's a table here, the middle two tables, they're not very clear, and I apologize for that, but they have specific metrics that have been developed in consultation with our pharmacists that we feel are indicators of potential risk with dispensing and prescribing activities. So some of these are the percentage of their claimants that are receiving certain types of medication. We use buckets of doses and the number of claimants or clients that are within those different buckets and see how they've changed over time. So these kind of report cards exist for benzodiazepines, opioids, gabapentin, and stimulants, and then there's a composite report as well, which is the summary of all of their different dispensing or prescribing. So kind of the process that we follow now is that on a monthly basis, we review the activities within a certain jurisdiction. So every jurisdiction is evaluated every 6 months. And if we have prescribers or providers that have been deemed to be of concern or behaviors of concern, there's engagement efforts from our pharmacists to discuss with the prescribers or the providers about their dispensing to try and understand what's going on with them, if there's any support that we could provide to help dose, to reduce doses and things like that. But we also track the interactions that we have with these providers and prescribers, and we need to know what's happening with them after we've had some sort of interaction. So we kind of categorize things into various tracks, whether a provider or prescriber is in an engagement track or just on an ongoing evaluation. So the bottom graph that we have here is quite useful to us because we can update this at any point in time that we want using our data warehouse. And we have this 3-month rolling window of time, and we'll use the 3 months to develop our dose calculations. So we can see at any given point in time how a provider sits in terms of their prevalence of clients receiving a certain medication, their median daily doses, and how that relates to others within their jurisdiction. So we can make a rapid assessment as to whether or not we need to re-engage with them or not. And we do have formal processes in place now which specify at which points we are going to re-engage with providers and prescribers. But an interesting one as well is the top graph shows the cross-reference report. And it identifies the relationship between pharmacies and the prescribers to see if there's a certain prescriber that's driving the behavior at a certain pharmacy, And if that's the case, the engagement may change significantly. As opposed to engaging with the pharmacy, we may go straight to the prescriber. So it's all about an education piece. And if there are situations that merit escalation to colleges and things like that, that does take place. But the primary means is to try and address issues of potential client safety with these drugs of concern through the evaluation and analysis of the data and reaching out to the prescribers and providers as necessary. So the final slide I have is just the change that's taken place since these activities have come into play. We can see that there's less clients that are receiving. The doses have decreased, and the overall volume or the prevalence at each provider has been reduced. Now, this isn't solely as a result of the prescriber and provider surveillance. We've also implemented some dose thresholds within the program, which automatically prevent adjudication of claims when a client's dose may be exceeding a threshold. And if that's the case, there are means to provide access to the medications if it's deemed necessary.
So thank you, Jennifer. I was struck yesterday by a story that Chris Powers shared with us from a few years ago, where she was telling us how her leadership team at a health region struggled when they were asked the question, what are we doing best and what are some of our biggest challenges? And I think, it made me reflect that that's an area where, as a system, we may have gotten a little bit better at sharing that information over the last couple of years. And the information is available from, disease organizations, quality councils, and CIHI has been thinking a fair amount about that as well. So how can we help design a visual that gives people a big picture sense of how they're doing, and helps them set priorities that would guide further analysis? So today I'd like to share with you just a couple of ways that we try and have a big picture visual. And they're all going to look different from each other because they're designed for different audiences, from people who are very interested in the international perspective to those who are more focused on what's going on in their own backyard. So the first one is a busy visual, but it does contain a lot of information. So this is one that shows how Canada compares relative to other countries. And it might be of interest to a senior government official or a health policy analyst who's trying to identify priorities at a big picture level. So the top circle shows 5 dimensions that the OECD uses to categorize their indicators. So you could be interested in access to care, you might be interested in quality. In this particular graph, we've focused on the 12 featured indicators for health status. So the 0 line, or the middle, shows what the OECD country average is. For each indicator, there's a shaded area where the bottom of it is the 25th percentile and the top of the shaded area is the 75th percentile. So you can see quickly that a wider shaded area means that there's more variation amongst the international countries. Canada's marked on this graph with a red dot. And you can see that there's areas where Canada does very well, such as stroke mortality. And there's other areas where Canada falls, below the 25th percentile. So we look at cancer deaths for women or traffic fatalities. And there's also an ability to see how your province stacks up against Canada as well. So this would give you a very, view at a glance as to some of the indicators you might want to look into more. And there's obviously lots of drill down capacity with this visual. The second front page is really designed to answer the question that Chris and her team were wrestling with a couple of years ago, where they were trying to say, where are we doing relatively well and where are some of our challenges? So in this particular graph is available part of our yourhealthsystem.ca website. And it shows 2 important pieces of information. It shows both how well a facility is performing relative to its peers and how the trend is changing over time. So the rows here show how well you're doing compared to your peers, where the top row is where you'd like to be with above average performance. And the bottom row is the one you'd rather avoid, so that's where the below average performance is. The columns show how performance changes over time, and in this case it's a 3-year window, where the far right shows indicators where the results are improving, and the far left shows where they're getting worse. And the numbers in each of these 9 boxes indicate the number of broad health system performance indicators that fall into each area. So again, looking at this, you'd be most pleased with the indicators that are in the top right, the 2, where you're doing better than average and the trend is improving. And you'd worry probably more, and probably many region CEOs would be more focused on the bottom left, which is where things are below average and headed in the wrong direction. So with a quick click, you could find out that that one indicator for this particular health region is readmissions to hospital. And it would take you to another, again, big overview page that gives you a quick sense of how are you doing relative to the rest of regions in your province. And when you look within your own region, in the blow-up box on the right-hand side, it would give you a sense of, is this a single facility that has these challenges, or is it shared amongst other facilities? And that's really what would quickly, I think, guide the further data analysis that you'd be interested in doing to really understand the issue. The third and final sort of front page visualization that we have is from, also from CIHI's Your Health System, but it's the Insight portion, which is available to authorized data analysts. And it's really focused on a very different audience. It's less stylized, but very functional. And it's addressing the same challenge. It's addressing this readmission indicator. And what the bar graph in the middle there would very quickly show the data analysts that readmissions are most common for COPD and heart failure patients. Along the left-hand side, there's lots of ways for that analyst to drill into this information. For example, they could look at standard slice and dice options like age group, month of the year, discharge disposition. And they could also look at some that are customized just for this indicator. For example, they could see the number of days between the initial admission and the readmission. So those are examples of 3 different sort of big picture, front page visualizations, all designed for different audiences, and hopefully help each of them drill down and find the next step of analysis that they need.
I want to start the conversation by picking up on something that Gary said. And Gary, you talked about the fact that measurement alone is not enough. We need some other ingredients to make change. So I'd like to ask you guys collectively, what's the most interesting example of change that you've seen from the use of these kind of tools? What's the most impactful, most interesting change? Who wants to jump in? Raza.
Okay. I may be off target here, right, when it comes to change, because the kind of things that we do are point-of-care decision support.
Sure.
Right, so it doesn't take into account the policy per se, right? And what we have noticed, right, because of just this one project that I was sharing with you, which was ImpactAF, it is a clinical decision support system that is right there at the point of care of family physicians, right? And as you are providing them more and more insights about their patients, their practice, and also complementing it with recommendations, right, that what you should be doing and projections of where your practice and your patients are going. What we are seeing is that in the initial stages, right, there was some degree of reluctance and apprehension towards the recommendations that were being provided, right, and also a reluctance in uptaking those recommendations because medicine is more an art than a science. That was the kind of right. So, but over time, what we are noticing is that it is changing. All right. The physicians do believe now that the projections and the insights that we are giving them, right, is helping them focus on their patients in a much more timely fashion, in a much more personalized fashion, and the recommendations are really corresponding to how they would actually like to improve the care of their patients. So at a point of care level, I believe that providing the right information at the right time is definitely making a difference in the behavior and capacity of physicians to deal with certain situations that they may not have the ability otherwise.
Thanks. Anybody else want to jump in? Stéphane?
I'll piggyback on that a little bit in that, to his point, we have examples where, successful examples within the system. What it makes me think of is more of, then why isn't there more of this? And many people today talk about the triple aim approach, and that's been being talked about for a long time now. Now, one of the early lessons I got from talking with the IHI folks was them highlighting to me a very significant difference in Canada versus the US. For that approach in the US, when they're targeting a given population, that service provider is competing with other service providers. Where they see Canada as very strategically positioned is from a province perspective, we have that ability to have a collective response to that captive audience. So for me, from a provincial perspective, I'm seeing the data having an impact to get, as a system, far better appreciation now why primary health services has got to be a focus. A better appreciation that there's variability within our jurisdiction. I think from a decision support, a bit to what Gary was talking, is starting to learn from a governance to a front line, and it has to be reflected in that. Because if it's not, what happens is, I think, the fact now that we're not necessarily from the governance to the front line, and governance is provincial government, but it's also, we have boards, we have, right, so common priorities and so on, that's affecting our ability to have consistent focus and sustained focus over time so that we can translate these types of learnings into better results.
Kathleen?
Yeah, one of the things that I find very interesting is one of the more recent additions we have to the Your Health System site is long-term care facility performance. And I think that that's very personal for people in terms of a general public view, because it's often where their mom lives. And I think that the information, while it's been widely available within the sector, has not been available in the same way in a public and transparent way. And I think that that's actually driven a lot of change in long-term care facilities that are, truthfully, are thinly resourced to deal with some of this information. But having the public interested in it, the media interested in it, has sort of forced them to reallocate some more resources, I think, to quality improvement. And they've been very well supported by the quality councils, particularly in their provinces, in terms of initiatives to drive quality improvement around restraint use, around antipsychotic use, and different things like that.
Anyone want to jump up? Well, I have more questions, so I'll keep jumping in, but feel free, microphones, come on up. Don't let me monopolize the conversation. But I'm actually going to flip this around now and maybe pick up a little bit on what you were just asking, Stéphane, because I think, we've now been at this as a country in many ways, whether it's from the point of care all the way through to public reporting for a little while in different ways. So if you had to give somebody one piece of advice about what not to do based on your experience, what's the blind alley that you would say, you know what, we thought it was a good idea at the time, but actually don't go down that path again? Oh, I've stumped them now. Oh, good. Stéphane?
I'm not sure if I'm stumped because I can't find one answer, or if I'm stumped because it's obvious if we're getting together in conferences and so forth, and many conferences and talking about this so much, it means that by default, there's many things we have to stop doing. So it's hard to pick. So bottom line is we have to stop doing what we've always been doing, or else we're always going to get the results we've always gotten. I think it's from the perspective of the council, which has been a very privileged perspective, because we work closely with, we assess the performance of the elected government pertaining to health and Department of Health and RHAs and so on. it's where I've seen a real move is to not see this information as a threat, because this is a very competitive sector. These are people with high levels of training, education, and in many ways got to where they've got because they've performed very well. They were picked among people. So to not see this information as a sign of defeat, but rather as a way to just keep building. Yeah. One other added thing is I'm in many conversations often with the medical profession around this is how quickly we tend to put aside what is self-reported. So on one hand, we spend a lot of time saying how we have to do much better job at putting the patient at the center of what we need to do. But at the same time, if it's not administrative data and it's self-reported and comes from patients, well, you don't know patients, Stéphane, you know, they complain about this all the time and they're not really, and we downgrade that. So the self-reported is also important.
Gary.
I would say, don't think that any one thing is going to be a silver bullet. And in the work that we did with the dashboard I was showing you, it was at the time we didn't have a joint set of provincial priorities. So it was a bit of a shotgun in terms of, what are the metrics that would be important for people to know about and so on. I think, flipping your question on its head and saying, what should you do? I think it would be ideal if in a province or a jurisdiction, you actually took a priority or a very small number of priorities and did it from top to bottom. And yes, build the dashboard for it, but also build that bottom-up engagement and use of the information and frontline improvement, and really see the whole thing happen, and then go on to the next and the next and the next, rather than trying to do too many things at once.
Great. So Bill, I think you were standing up. I'm going to give you the last question comment with the feedback from the panel.
No pressure. No pressure. Fascinating to see all that's happening in each of your jurisdictions, so way to go. I guess my question pertains to, so how do we benchmark from one jurisdiction to another? I represent Canada's healthcare authorities and hospitals, and of course you've got Ontario as the control group with hospitals still, and all other jurisdictions with variations on the theme of health authorities. As we look at trying to develop standardized benchmarks, and I'm thinking of the work that Jack Kitts, for example, has been trying to do for about the last 6 or 7 years at least, and having trouble providing standardized metrics of a limited number that can help us all learn from one another. What can be done collectively to address that problem? The second, I got 2 questions, Jennifer, that's okay. It's related to the first one. Some of us were not happy when the Health Council of Canada was not renewed in its mandate. A number of people have said, well, let's look to the quality councils to fill that space, or let's look to CIHI to fill that space. To go from the what, so what, to now what. It's that third piece. And I think it bears on the question of providing the information out there is not enough. You need to have the change management tools to support moving that line, right? So 2-part question. What can we do to try and broker this differentiation between hospitals, healthcare facilities, healthcare authorities on the one hand, and 2, what can we do to fill that space that's been vacated by the demise of Health Council of Canada?
Who wants to take one or both of those on? Stéphane?
On benchmarking, 2 things. We had a health system renewal initiative in New Brunswick in the recent years. 2 co-chairs, John McGarry, who's currently CEO of Horizon, and where with, I believe it was Grant Thornton that they worked with, did some benchmarking from an efficiencies perspective. And it brought about some information that really kicked a lot of current comments in the face, in the sense of looking at, for example, New Brunswick's got, we say, 23 hospitals, right? But it's not really 23 hospitals, because the St. John Regional and the Saint-Quentin Hospital are not two same things. That benchmarking has helped appreciate that there was more efficiency to be found in one of our regional hospitals than the sum of all small hospitals put together, right? So the benchmarking was very important, but it had no traction. It had no traction. Like the work was done, the numbers were there. We just went through a strategic program review provincially, and my biggest frustration was that never floated to the top. It wasn't used. We didn't use that properly. Secondly, in our own work, here's our issue, is when we were reporting on New Brunswick and comparing ourselves to the rest of Canada, two parts. What we've done is, from a health service quality, is we've looked at indicators on a number of dimensions. And if you go on our website, you'll find the quality dimensions and indicators, and we're New Brunswick grades. So the approach we used was, we took the top performing province in Canada for that indicator, gave them an A, and a 7-point scale, and the last one's an F, and wherever New Brunswick would fall would be our grade. Fine, worked, it helped really position primary care as a priority thing, but it didn't answer the following question. What is an A? Canada is a bad performer, so we're the worst among the worst on some of these things, right? So our ability as a system to actually set targets and define what is, in absence of that, we came up with that approach, right? We said, let's compare ourselves and assume that the best indicator is an A. But is that really an A for Canada? On your second point, it's, the challenge for us at the Health Council, and as the Health Council of Canada closed and so on, is the debate for us often is, we're arm's length, we're different from Saskatchewan. We don't implement quality improvement. We're meant to be arm's length. The commissaire à la santé au bien-être in Quebec is the closest to us in that identity. So we're meant to be arm's length. We often get into those debates of, do we do health promotion? Do we do whatever? And our line is to say, our role is to enhance our collective understanding of where we stand. If we do that effectively, by default, the fact that we're stagnating should get more and more evident. If we're improving, it'll show we're improving. And if we're not, it'll show that too. And it's believing in the value of doing that, and then of having that reality, so that collectively then, it puts more onus on the types of things. And our work has led us to really put a lot of emphasis on the need to define, and somebody mentioned it yesterday, roles and responsibilities within the system. The department's doing a lot of stuff RHAs should be doing. RHAs aren't doing a lot of stuff they should be doing. So who's really responsible? If you're going to have accountability frameworks, who at the end of the day is responsible for that? And that's a key point. And so we highlight that, not being responsible for any of those service deliveries or the quality improvements in those service deliveries.
Kathleen, I think you wanted to jump in.
Yeah, so an interesting piece, just to your second question, is to think about at a very early stage in a measurement project, what's the change that you're hoping to see? And if you can get that thought through at the beginning, the measurement is just the one component of it. And I can think of a couple of examples where I think we've thought a bit differently to some good results. So one of them is around the antipsychotic use in long-term care. So that's an area where CIHI provides the measurement, but the quality councils and the CFHI collaboratives, and there's lots of energy around and different approaches around how do you get to the change you want to see. We're doing another big project on measuring harm that occurs to patients in hospitals, where we're partnered from the outset with the Canadian Patient Safety Institute, who's coming up with best practice resources that match some of the harm categories. So that it creates the receiver capacity for the information, which often takes a long time to do. And it gives the partner organizations the runway to get that ramped up and ready when the measurement is available.
I'm not qualified to respond to the first question, but on the second question, I think if you look at what we're trying to achieve, right, it has two parts to it, right, and all my colleagues actually pointed out, right. There is a measurement paradigm which we are involved in, right, the analytics, the reporting, right, and then there is an action paradigm, Right? The way I look at it is that we are very heavy on the measurement paradigm, right? And we are more likely to have more and more analysis, just like we had an information deluge, right, which prompted this analytics paradigm itself, right? But not necessarily the translation, and Stéphane also pointed out to the same point, is that how would this analysis lead to the change, right? So the action paradigm is not there yet, right? Now, there are two ways one can look at it. One is that we don't necessarily have a good sense of the determinants or the confounding factors that are leading to the inefficiencies or the deficiencies that we are seeing, right, again, Stéphane, your point over here. So how can I actually respond? I respond at a very gross level, right? I cannot do a surgical strike and say, this is it, right? So if we have a good sense of what are the confounding factors and determinants, right, we possibly could go directly into those elements and not at individuals or institutions or systems, right, but factors, right? And we don't drill down that deep because we don't have an action paradigm. The second thing is that despite all the data that we have and the analytics that we are doing is literally informing us about things that we definitely have a hunch about, right? And now it is a bit of an evidence, right? We are not taking that analysis one step further using advanced analytical methods, where if these factors are factored into it and you modulate those factors, it would actually tell you that if you make this much change over here, you're going to get this much change in your outcomes, right? A lot of other industries do that. Right? In fact, if you think about it, the presentation at the dinner, they were also doing the same thing, right? They know their key performance indicators and they know what contributes to it. They make this change, they see the outcome. We don't have this connection in health between information and action, and I believe that would again lead to 5 years that we would have pretty visualizations, but not necessarily very good outcomes because we couldn't translate that into an action plan. So I think that is the key, right? And at a physician level, this is where I work, in physicians and patient level, this is what we really target, that I can tell you that modulating these factors would lead to this kind of outcomes. It is up to you whether you take it or not.
Seems like an excellent spot, sorry, Bill, but I have a responsibility to this room to let people back in because this is the room we're assembling back into. But I actually think that's an excellent segue because as we come to the closing sessions of the conference, we're focusing on where do we take this, what is the action, how do we move forward? So you'll have a chance to get your point in then. Please join me in thanking all of our panelists.